because a lot of patients come to me and they say, yeah, I'm depressed and I'm anxious, but I'm depressed and I'm anxious because I'm not functional. So it's not primary anxiety, it's secondary. It's I'm depressed. I mean, you take any of us and say, now you can't earn a living. Now you're staying at home all day long. I mean, I give you a week to 2 weeks to a month and you're like, this sucks.
This is Dr. Meenal, and welcome to Uncover Your Eyes, where we uncover reality. As a mom and eye doctor, I want to know it all. Many of us have suffered a concussion. Many of our patients or family members have suffered a concussion. A concussion is a mild traumatic brain injury, or TBI. Its effects can be short-term or long-term, and essentially they can affect your entire life. With concussions, we see physical changes, cognitive changes, and behavioral or emotional changes. The CDC estimates 2.8 million hospital emergency visits, hospitalizations, and deaths in the US each year from TBIs, the majority being concussions. Today, I have leading experts in the field of concussions, Dr. Bruce Lidkea and Dr. Patrick Quaid. Dr. Bruce Lidkea is an optometrist with a fellowship in neuro rehab and the owner of Lidkea Optometry. He is also a member of the International Sports Vision Association and the College of Syntonic Optometry. Dr. Patrick Quaid is also an optometrist with a fellowship in neurovisual rehab and the owner of View Cubed Vision Therapy clinics. Having suffered a severe TBI at 8 years old himself, he knows firsthand what a concussion can do to the academic potential of a child. Welcome, Bruce and Patrick. Thank you, Bruce and Patrick, for being on this morning. Really appreciate your time.
Happy to be here.
Thanks for having us.
So, Bruce, tell me a little bit about what is a concussion and how do you know you've had a concussion?
Well, according to the Amsterdam panel on concussion, a traumatic brain injury caused by a direct blow to the head, neck, or body, resulting in an impulsive force being transmitted to the brain that occurs. Normally, this is involved with their sports panel, but the big thing is symptoms and signs can be present immediately or evolve over hours to days. And now, normally it resolves, but a lot of the times it doesn't.
And how is it happening? Like, can it be from, just a ding to the head?
Well, not necessarily just to the head. I've had lots of patients that have come in that have just slipped on ice and fallen, and that jarring effect will do that. And a lot of that has to do with the difference in density between the white and gray matter, causing some axonal shearing, or there's that physiological cascade of the damage to the neurons.
Wow. And Patrick, like how common are concussions? Are we seeing it all the time? How common would you say it is?
Well, I mean, if you look in the literature, we see probably about half to 2/3 of our clinic is concussion. A lot of it is more pediatric concussion now is what we're seeing. Cases coming in, actually, a lot of them masquerading as learning difficulties, believe it or not. So you start to look into these cases and they present as, a kid with an IEP or a learning difficulty at school. And you look in the developmental history and there's no real history of prematurity or low birth weight or anything developmental. And when you talk to the parents, you often hear, oh yeah, when they were 5, they fell down the stairs, or they fell playing soccer, or they didn't necessarily have a loss of consciousness, but they had what's called an AOC, or altered consciousness. So when you talk about how common these things are, it's estimated that out of if you get 100,000 population, you might get. Sorry, let me rephrase that. You get about 15% of concussions that result in post-concussion syndrome. So if you get 100 people that have a concussion, the good news is the vast majority will kind of bounce back, but you get about 15%, 15 out of 100 that won't. And typically they'll have prolonged symptoms such as neck issues, vision issues, light sensitivity, and things like that. But when we go back to the definition of concussion, so a shout out to Eric Singman at Johns Hopkins. He's an MD PhD. He was a chief in neuro-ophthalmology when we wrote the book chapter in the book called Neurosensory Disorders and Mild Traumatic Brain Injury. And Carrie Balaban, I believe, is in Pittsburgh. the chapter 1 of that book answers exactly that question. What is a mild traumatic brain injury? And I'm just going to read this quickly because it's kind of interesting when you look at the NIH definition. And I'll read this quickly and focus in on the vision part of this. It says a person with mild TBI may remain conscious or may experience a loss of consciousness for a few seconds or minutes. Other symptoms of mild TBI include headache, confusion, lightheadedness, dizziness, blurred vision or tired eyes, ringing in the ears, bad taste in the mouth, fatigue or lethargy, a change in sleep pattern, behavior, or mood, changes in trouble with memory, concentration, attention, or thinking. But when you look at that blurred vision and tired eyes, I mean, what does that mean? It's extremely vague. So to answer your question in short, I mean, concussion I don't think is uncommon. Is it getting more common? Probably, but I think it's also because we're becoming more aware of it. I think as clinicians, we're paying more attention to patients who present in our clinics with, be it whether it's neuro-optometry working in the optometric rehab realm or whether you're a physiotherapist or an OT, patients coming in with these types of symptoms, I think we're getting better at asking questions, even if you haven't had a loss of consciousness. I think the hang up in the past on loss of consciousness has been overly emphasized. The vast majority, there's some research actually showing that loss of consciousness actually results in cases that have better visual memory outcomes because the person sought care. If you didn't have a loss in consciousness, typically appropriate care is not sought as often because we have a hang up that a loss of consciousness has to be involved, which is complete nonsense.
And I
Right.
think that there's an easy definition for concussion as well, and it's a history of trauma followed by a change in neurology.
Yeah.
That's really all we
Yeah.
need.
Yeah. And like you said, it can be as small symptoms like just a small headache after or fatigue after, even just basic symptoms that we almost pass off, right? Or we ignore, so we don't seek that help. So, Bruce, tell me like what type of when someone suspects they may have a concussion, who are they visiting? Where are they going? What should they do?
Well, I'm a firm believer, and I think Pat is too. It's structure before function. So you want to get checked out at the ER. You want to make sure that there isn't a skull fracture. You want to make sure that the neck is fine. You want to make sure that there's no damage or bleeding in the brain. But after that, it's you need to come see a neuro-optometrist.
And who else would be involved in that care? So, I know you mentioned the ER visit, the neuro-optometrist. Are there other professionals that they should be seeking care from?
Well,
Pat?
yeah, I think in terms of the team, we use a 6-vector questionnaire actually in our office because obviously the six aspects of
Okay.
concussion. And I've sent the document to you if you want to post it. Feel free. But there's 6 vectors from vestibular to vision to cervicogenic to migraine, anxiety. So you have different. Every concussion is different. If you've seen a concussion, you've seen a concussion. And I think it's important to look at every case individually and work it up from that perspective. But in terms of the sequence of who you see, my opinion is I think neck has to come, and again, exactly what Bruce said. You got to rule out pathology first. We'll assume that's done. Once you've done that, my opinion is the vast majority of cases, I'm talking like 90% of the middle of the bell curve, are going to be neck and back early, vision very soon thereafter, and vestibular once you've dealt with neck and the visual system. The reason being, if you do vestibular therapy, it basically involves you moving your head from side to side and looking at something. Well, if your neck's a mess and your vision's a mess, that's not going to be very successful. So vestibular therapy is important, but it has to come in the right place. So I'm a big fan of cervicogenic neck first, vision very soon thereafter, and then vestibular, and then an overarching, where appropriate from a psychological standpoint, making sure, depending on how chronic the case is, um, you know, we unfortunately in our adult cases, our pediatric cases are quite different, but our adult cases, we're not seeing these patients tragically till 3, 4, 5 years post injury. We're almost always the last people to the party. So when we see these patients, there's usually quite an overlap of psychological things going on. So I think that has to be taken into account too.
And
Yeah.
I saw a recent stat on, like 20 to 30%. I don't know if that's even right, but that's a lot of concussion patients. 20 to 30% are experiencing depression within the first 6 months of their concussion. Bruce, are you seeing that, a lot with your patients who have had concussions?
Definitely. I think that the stat is it's actually 50% of patients that have had a MTBI within the first year are affected by depression. Now you bring that up to 7 years post injury, and I think it's around 2/3. So it's a pretty significant number.
Wow.
And I
So,
think
I mean,
something to also mention too, to follow up on what Bruce said, which is 100% true. Um, I believe the Canadian Medical Journal, the Canadian Association Medical Journal, in 2016 published a paper, and the sample size was huge. It was like 230,000, I think, was the sample size, and they looked to see, out of patients that had a concussion and subsequently developed post-concussion syndrome, what proportion of those patients tragically took their own lives. And what they found was a tragic stat. It was 3 times the national average of what you'd expect to see. But the most tragic statistic in the paper was when you zoomed up, I think it was 667 poor souls who took their own lives. They looked in the medical records and they had taken their life within a week of seeing a medical professional. So I thought that was a very tragic statistic. You look at it and say, the notion that these patients are not seeking care. Yeah, there's a whole bunch of them that potentially aren't. But when that happens within a week of a medical visit, it's like, okay, we often see chronic cases where, these patients are, I'm also a officer in the reserved armed forces in the Canadian Armed Forces. And this stuff is pervasive, especially when you start to look at police and you start to look at the military, stuff coming out of the US is very clear on this. And I think in the general population, this study was done in the general population in Canada. So these are homegrown stats to say it's post-concussion syndrome patients are 3 times higher suicide rates, and over half of them that tragically follow through and do it have seen a healthcare professional within the last week of life. I think that should be a wake-up call for healthcare professionals. Say we need to start asking more questions.
wow.
100%. I think you have to ask those patients. Are you having suicidal thoughts or thoughts of self harm? And do you have a stable and supportive network of friends and family? Certainly if there is any indication that there is the possibility of suicidal intention, then you have to get a neuropsychologist involved.
Right. Do you have, Bruce, like a story of a patient where you feel, touched your heart, that you really, helped through that process of, their mental health?
Probably several, but I think that probably the most impactful thing I can say is that I've been practicing for about 30 years, and I've been doing neuro rehab for probably I started about 10 years ago. I've been going pretty full force for the last 5. I've had more happy cries in my chair in the last 5 years than the other 25 put together. Because when a patient comes to see me, they've already seen their medical doctor, their regular optometrist, their physio, their chiropractor, a neurologist, and they're coming into me either just in desperation or despair. And a lot of them, and some of them just think, well, this is just another box to tick. You're not going to help me either. And then when we can actually show that a lot of the problems are visual, not sight related, but visual, then uh, there's this epiphany. Oh, I'm not broken,
Yeah.
and it makes a huge difference.
Yeah. And Patrick, like, do you feel the same way? Do you feel like,
Yeah.
by helping them, you've helped their mental health kind of as well?
Oh, we've seen patients leave after one visit, and it's yes, it's a process. Visual rehabilitation is a process, but the validation that there is something wrong, that it's not just them feeling gaslit, going, I'm seeing all these people, they're all telling me I'm fine. Why do I have these symptoms? I've stopped telling my spouse. Now my spouse doesn't believe me. They think I just don't want to go back to work. One of the stories that sticks out for me, and I can say her first name because it was actually on CTV. This actually was put on the TV, which was awesome. How it got to the reporter, I have no idea. I think it was through a family friend or something. But Hanya came to our clinic, and we'd seen her before for VT more from a amblyopia standpoint, but she subsequently had a concussion at school. And she greatly benefited from yoked prism in her glasses, because when she was walking, the floor would look tilted to her. So she would adjust her gait to make the floor look flat, and she was drifting off to one side. And we got an instant response in just by putting the lenses in place. Now we still had to do the therapy, but it was so instant with and without the glasses. One of the reporters got a hold of the footage. It ended up on CTV. Like her life has been changed, because I think she was like that for 9 months before she saw us. And it was, to see a kid
Wow.
that tugs at me. I mean, probably the story I should tell is the one for myself. I mean, when I was 8, I was in a car accident, and I was knocked out of commission for 2 years. So this is how I got into this. I mean, I did my PhD and my postdoctorate in uh, visual psychophysics, which sounds really boring. But if I tell people it's really, I studied illusions and how the brain sees, that sounds way more cool. It's because, Bruce touched on something that's really important, which is vision versus eyesight. Eyesight's what I see on the chart. Vision is how my brain puts it together and makes the world look cohesive to me. And that's when you realize 40 to 50% of the human brain is visual machinery, and it is by far the most dominant sensory system. It doesn't mean vestibular is not important, cervicogenic is not important, hearing is not important, but vision is our most dominant sensory system. And there's tons of illusions out there that prove that. If you have hearing and vision, like the McGurk effect, if you look that up on Google, anyone listening to the podcast, just type in MCGURK, the McGurk effect. It's somebody talking saying ba, ba, ba with a B, but then if you change the mouth movement so it looks like an F, like you hear fa, what you hear changes. So vision is so dominant. It's not that it's the only player, but if you don't get it in check, if you don't get it functioning properly, it can really spill over into the other areas, not just from a vision, but from a vestibular perspective, from a psychological perspective. Because a lot of patients come to me and they say, "Yeah, I'm depressed and I'm anxious, but I'm depressed and I'm anxious because I'm not functional." So it's not primary anxiety; it's secondary. It's I'm depressed. I mean, you take any of us and say, "Now you can't earn a living. Now you're staying at home all day long." I mean, I give you a week to 2 weeks to a month, and you're like, this sucks. So I think we have to differentiate. To Bruce's point, we collaborate a lot with a psychologist who has actually told us, because you have a patient in your chair saying, "Yeah, I've had days where I've thought about taking myself out," versus I'm driving around in my SUV and I have a noose in the back of my truck. Like those are very different statements. One is active suicidal ideation. The second one, the first one is, they might be ruminating about it, but it's not active. In both cases, you should have a psychologist involved, but it's patients don't tend to get there. In my experience, I mean, Bruce, you can chime in here. Patients don't, in my experience, don't get there until they're 6, 9, 12, 18 months in. When they're in that 6 month range and they're getting the proper treatment, they don't tend to go down that black hole,
Right.
right?
Well, yeah, I think that's beautifully put. I think there is a big difference between thinking and planning. If you're wondering about the two, ask them if they got any plans in the future.
Yeah.
If they've not made any plans, that's a big red flag.
Yeah.
But
Yeah.
and that's over this year. I was lucky enough to take that mental health first aid course, and uh, game changer. I think that's one that every optometrist should take, because we all have patients that are having mental issues, and just be able to talk to them better, and better understand what they're going through, and that's available. That's an international course. It's available in Canada and the U.S. And I just talk to your Canada Mental Health Association, and they'll put you in the right direction there. And then, of course, the assist program is another good one. That's the what is that called? The applied suicide intervention skills training, and that's another one that's well worth all optometrists taking.
Yeah. I always say like healthcare is now collaborative, right? Just like concussion therapy, patients are coming to us with other issues. They're going to their dentist with other issues. They're going to
Mm.
every health, their chiro, with mental health issues or eye issues, even to their chiro, right? Everybody is kind of crossing professions. So it's so important for us to be collaborative and understand, or at least be able to direct patients in the right direction to neuro, to a team that can better care for them. So to your point, Patrick, like, that patient that you were talking about, who, it was, I don't want to say simple, but a pair of glasses to help, with Prism to help balance her world is life changing for her. Otherwise, like you said, she might have been at home for months and end up. So psychology or the mental health part of it is usually secondary from things not being treated initially. So important for us to direct them to the right professional. From and anyone can take this one. As an optometrist, what is like I know there's so many effects visually, like you mentioned. So what are the steps or the things that you're checking as an optometrist?
Okay, well, I think the first thing that we want to do is get an idea of it's just like primary care. It's history, history, history. So we want to get those those surveys and questionnaires that are going to be hard hitting, so that and every primary care optometrist should be using a brain injury vision symptom survey just to suss out which ones need to come to see neuro rehab optometrists. I think that's a great one. I love the HIT 6 for headache impact. Certainly the dizziness handicapped survey is a good one. But there's lots of them out there. And the low hanging fruit, I think that the vast majority of patients that come in with mild traumatic brain injury end up with dry eye. So doing that SPEED or the OSDI beforehand and treating that immediately is going to make our lives a little easier.
Patrick, what would you say the effect is like on, your reading and the basic things that kids are doing in school? Would you say there is effect on that, and how are you helping with that?
When we talk about kids, I think what you find with reading with children is what you'll often hear from parents. If a kid has had a concussion and they're not bouncing back, what you'll often hear is, ever since the hit, it's been, I don't understand it. My kid's smart at everything except school. That's the phrase I've consistently heard from moms, right? And it's like, what do you mean by that? Well, if I read to them, they'll do fine. But if they read, they fall apart. They have trouble finishing their tests in time. They used to love school. They're drifting away from school. And I think, if the kid has an IEP, when you go back to that question about what should primary care optometry or primary care of any healthcare profession, to be honest, if they sit there and say, what simple test can I do in clinic? And my answer is ask a couple of simple questions. Number one, if it's a kid, is there an IEP in place? Do they have an individualized educational plan at school, which is the school giving that kid extra help? That's a red flag. Then you should be asking about, okay, were they preemie? Were they low birth weight when they were born? If the answer is no, start thinking concussion, because that's what we find in our office. If they're not developmental, they're brain injury. Like there's not a lot of in between. You also have to remember about 70% of the symptoms of attention deficit disorder are identical to the symptoms of just convergence insufficiency. So if a kid can converge appropriately, so if I'm a primary care optometrist, what's a simple test I can do? NPC. You need about 13 to 15 different areas of the brain to be working in parallel properly to have normal convergence. So it's a great screening test. Now, mind you, if you fail the test, then good luck in trying to pinpoint where the issue is. But it's a very good screening test. So just a simple NPC. Bruce talked about BIVS, the Brain Injury Vision Symptom Survey. It's a good questionnaire. But I think another one I tend to ask for is light sensitivity, and also tolerance of visually busy areas. That's a big one. Going into grocery stores, malls, Costco type settings. We actually call it the Costco test in our office. If a patient's like, am I ready to go back to work? Can you last in Costco for a half an hour to an hour? The answer is no. The answer is you're not ready to go back to work. I think the other thing is in terms of gauging whether somebody has had a concussion or not, or whether if they've had a concussion and it's a significant, because here's the thing. I've got kids, right? Yeah. I mean, kids fall and hit their head all the time. So as a parent, how do I know when it's a knock versus when it's a concussion?
Right.
And I think it's when you start to see persistent abnormal function, things like reading difficulties, things like copying from the board, things like a big thing is spelling in kids. This is something actually we just published a paper this year, 2024, in vision development and rehabilitation. And we looked at a cohort of kids that had dyseidetic reading difficulties. Let me explain that a little bit. It's important. So if a kid has trouble reading, right, it can be dysphonetic or dyseidetic. So dysphonetic means I have a problem with my phonics. I need to go see a speech pathologist. All that's fine. So, if you ask a kid to spell future and they spell it with P's and Q's, then they have no idea of how letters and sounds go together. They need to go see a speech path. But if you get a kid who's got spelling issues persistently at school and they spell future, Fucher, future, that is how it sounds. So English is a nutty language. I'm from Ireland originally, and trust me, English is nuts. I don't know who invented this language, like there, and there. Like there's three different ways of spelling it. Spell yacht, like really, YACHT. So English is not unique, but it's definitely the more visually based language where I have to remember what the word looks like, even though it sounded out different to how it looks. So if you get a kid who is persistently spelling phonetically, so station is STASHUN, right? Future is FUCHER, because that's how it sounds, right? So if that kid is overly phonetic and can't remember what words look like, that's called dyseidetic reading issues. So dyseidetic will typically not benefit very much from speech pathology intervention. Dysphonetic cases will benefit from speech pathology intervention. So along the lines of what Bruce said earlier, it's like diagnosis before prognosis. You have to know what you're dealing with. So going back to the question of primary care, if you're an optometrist or a primary care physician, and you got a parent coming to you saying, my kid struggles in school, you say, okay, is there an IEP in place? Oh yeah, there's an IEP. Okay, what's the IEP in place for? 80% of the time, it's in place for reading. And if you say to that parent, does your kid struggle with spelling? And they say yes. And I just ask the kid to spell station and future and watch how they spell it. If they spell it phonetically, it's a visual memory problem. Concussion goes way up on your differential. So I think you have to start asking then, okay, if your kid wasn't preemie or low birth weight, have they had any knocks or bangs, even if they weren't deemed a concussion? Have they had anything that was like they had their bell rung, or they played hockey, or they fell, or there was something significant? I've actually had parents go back through their kids' grades, and they'll say, oh, now that you mention it, I went back to like when they were in grade 3 and they had the knock, and now I can see the grades going down, specifically in English and in more the language-based stuff. And math didn't drop until the kid hit the questions that involve word questions.
Ah,
So when they have to read them, that's when the grades will start to drop. So it's just knowing those things as a clinician and just knowing when to key in. Because as primary care docs, like, we're busy. We got a million different tests to do. So someone's like, screen for this, screen for this, screen for this. My question is, if you were to just ask one simple question, any history of potential concussion events, and does your kid have an IEP in place at school? Two questions. And you would cover, if they have an IEP in place, we have published a paper showing there's about an 84 to 86% chance that they have a significant deficiency in either saccades, accommodation, or convergence.
Yeah, I love the phrase, if you are a kid or if you ever were one, you've probably had a concussion.
Yeah.
That's
Yeah.
that's a thing. And the way that I kind of explain it too is it's that drop a laptop. If you drop a laptop, you pick it up, you shake it, there's no broken parts, but it doesn't run right.
mhm,
Drop 10 of them, they all don't run right, but they all don't run right differently.
right.
So it's every one of them is you're going to do an awful lot of testing to see what sticks to the wall.
I love the point also that, we should just be adding this to a history form, a basic intake form. Many healthcare professionals don't have concussions on their intake forms. We have a generic medical history, and that's important because, like you said, I have a lot of patients that I see myself that, have IEPs in place, and I don't think I've asked, every single one, about concussion history or falling history. And I think that's so important for us to be addressing that. We also don't do anything until the patient has symptoms, right? So we won't ask for the IEP or about an IEP unless we see something like the patient's experiencing double vision or something like that, or, we won't really ask those questions. So, but like you said, if we identify it and then we, even if we don't have time as primary care physicians, optometrists, whatever the profession is, at least being able to direct it and identifying it to solve the problem is huge.
And I think sometimes the patient doesn't know how to answer. Like if you ask, have you had a concussion? Nope.
Yeah.
But you know that they're a hockey player. And well, have you ever had your bell rung? Oh yeah, tons of times.
Or you'll get the hockey players. I mean, we dealt with I won't say the name of the team, but we dealt with an OHL team and a couple of NHL players, which is interesting. And what I found is a pattern is on their baseline testing. If you've ever heard the phrase sandbagging your baseline testing, so they will on purpose, get this, like the psychology behind this is astounding. They will on purpose underperform on their baseline testing because they don't want to be taken out in case they have an injury. It's that competitive, right? So we changed the narrative with one of the OHL teams. I said, no, we're going to set the norms, because if you're an OHL player, you should at least be able to get to the age population norms. So you're not getting on the ice unless you pass a certain level, and we're not telling you what the level is. So now what's going to happen is they're all going to try to reach for their highest every single time. And it's a subtle change in language. A paper that we published with the University of Toronto, I think it was about 4 years ago. I sent you the paper, so if you want to post that, you can. But we looked at 254 varsity athletes that had concussions and been cleared to play. The vast majority had concussions and been cleared to play. We found about 20% of them, and my hats off to the University of Toronto and Michael Hutchison. He's a professor of kinesiology there. My hat's off to them for publishing it, because it's like these were people who were cleared to play. And we went in and did our testing and found that on average, depending on the test, about 1 in 5, about 20% of them were failing significantly on at least one important ocular motor metric. So it's like these people were cleared, and then when you zoomed up that 20% and you gave them the BIS questionnaire, the Brain Injury Vision Symptom Survey, which is a very simple questionnaire. It's a bunch of questions. It's a scale of, I think it's from 0 to 112. Any score over 32 is abnormal. The vast majority of that 20% that had trouble on one of the three tests had a significantly high BIS score. So like these are, and when you talk to them and said, how's school going? Like your third level education, how are you doing? I'm struggling. That's what you heard from most of them. So these were people that were cleared to play.
Wow. Yeah, I think the majority of concussions is from sports. In the US, I think there's 2 to 4 million, sports related or activity of sports related, whether it's competitive or not, just athletes, concussions. So that's huge. But interesting that you said that, because I didn't know that phrase, sandbag phrase. But I mean, like, that's interesting, because most of us wouldn't know that they're getting tested for concussions, and they're underperforming just so that if they had a concussion, then they would pass.
Well, I mean,
And
think about these folks who are wanting to go from the OHL to the NHL, so they're not going to admit it when there's a problem. And the tragedy is, if the problem's uncovered, it can be not simply treated, but relatively easily treated, especially if you catch it early and it's not multiple injuries in before they finally admit that there's a problem. I find most of these athletes, when they come to us, it's not the first injury; it's like the third or fourth.
Right.
And when we're doing these, you're taking a patient that was functional and has now had an injury and is dysfunctional back to functional. But the overlap between neuro rehab and sports therapy is very big. So what ends up happening is you get these athletes that have had a concussion, they go through therapy, and all of a sudden you've changed them from functional to optimal, and
Yes.
they can actually improve their game. And we've seen that a lot with kids that all of a sudden, just kids coming in for regular vision therapy for a CI, and they're doing that, and all of a sudden the parents come back next year. Yeah, you're right. The school is saying that they're doing amazing, but he is killing it on the ice this year, and that's what we want to see. It's a whole person. It's a full functioning person.
Well, along those lines, and it's funny you mentioned that, a slight change in terminology. If you say rehabilitation or therapy, athletes don't like it. If you say enhancement, they're all over it. And like you're pretty much doing the same thing. You're pretty much doing the same thing. As Bruce said, it's two big overlapping Venn diagrams between rehabilitation and enhancement. And I find, not that we need to do VT on everybody, but you take the average person off the street, you do a visual skills assessment on them, they're not going to be perfect in every area. So the average person could probably be fine tuned. So you take an athlete who's looking for a 2% to 5%, an 8% improvement. I mean, for the average person, that's not a big deal. For a professional athlete, that's huge.
Absolutely. And I find, I like the word enhancement, because that's huge, like, to parents. A lot of parents are really gung ho about their children, becoming competitive, or, at ages 8, 10 years old, they want their
Mm.
kids in competitive basketball or whatever the team is, hockey, and enhancing is huge. So I think that's a word that a lot of us as healthcare professionals can use, rather than saying, you need neuro rehab or you need vision therapy, which sounds like your child might have a disease. Just enhancing their performance is such a great word to use. A lot of parents would opt into that. So I love that. And you don't know, maybe your child has had a mild concussion or had a fall. My 4-year-old's had a big fall, and you guys got me second guessing this now. That I don't know what the consequences, or what's going to happen later on. But I don't think I would have ever thought of that unless I talked to you guys. So I would have just thought he's fine now, right? So
Well,
a lot of parents don't write this down or remember. So I think it's important to keep a diary, know what injuries your children have had, especially if they're in competitive or these types of sports where they're getting injured a lot.
And
and
if you
I
could
think,
go ahead, Pan.
go ahead, Bruce, it's all yours.
Okay, if you actually enhance the attentional field, or the visual decision making on a patient, or their multiple object tracking, you're actually going to decrease the likelihood of them suffering another concussion. You're going to improve their safety profile.
That's
Yeah, and I
interesting.
think what you said before about as a parent paying attention to these kinds. I mean, I was lucky because my parents really, after I had my car accident, the only reason why my vision issue was spotted was because I had a speech issue as well. I developed a stammer afterwards. So my SCMs, my neck muscles actually tightened, my head posture went forward, and my speech was messed up for about 18 months. And it was a nightmare. But on top of that, I had a CI, so I saw double. And I distinctly remember having a page in front of me. I know kids are wonderful adapters, so I just turned my head slightly and used my nose to block one eye, and that's how I read. And my dad was in the military, my mom was a nurse, and we must have gone to 8 or 10 optometrists, went to 2 ophthalmologists as well. And finally, my dad took me to see an optometrist who was actually involved with the military. And when he was assessing me, he just picked up a pen, said, "Have a look at the pen." And I just said, "Which one?" He's like, "What do you mean?" I'm like, "I see two." And he turns to my dad and goes, "And you're wondering why you can't read?" And I'm sitting there 18 months into my injury thinking, like, finally, I've got somebody who I'm now convinced that I'm not stupid. And when I go back to that, it's and I won't turn my head around on the podcast, but I just got my hair cut, but on the back I've got a scar about that long on the back of my head. And I think it's realizing it was not taken seriously because there was no loss of consciousness. Like, they took me to the hospital, had a CT done, but there was no loss of consciousness. And I just distinctly remember my parents saying, the doctor said there was no loss of consciousness, so we wake him up every hour tonight, make sure he's okay. That was the management. That was it. And we think that was back in the 80s, but you kind of think, well, things have changed now. I mean, yeah, things are more fancy, we can do more scans, but has the management really changed that much? I think it's getting better. I mean, if you look at the year 2000, if you did a PubMed search for concussion, there was I think there was probably about 20 publications in 2000. In 2017, there was 185. So, like, the literature is exploding on concussion because people are paying more attention to it, and good. But I think it starts at home. It starts with the parent. Nobody knows the child better than the parent. So if you see a change in your kid, and you're like, something's not right, and it was only because my parents pushed, because my dad was a bilateral +8, didn't get his first pair of glasses till he was 11. So you imagine his primary school was probably a nightmare. My mother was an amblyope, so she had a lazy eye, and I hate that term, lazy eye. It's like if your leg doesn't work properly, you don't call it a lazy leg, right?
Yeah.
Um, she was a strabismic amblyopia, and she was 20/40 in her good eye, 20/80 in the bad eyes. Like, both my parents grew up with vision that wasn't great. So when they started to see me struggling visually, in addition to the speech issue, it was like, for them, it was like, no, we're not taking no for an answer. And they kept on, and a lot of parents, um, we talked about this earlier, but it's the best doctors are the ones that get other doctors involved. The worst ones are the ones that think they know it all. And I'll say that very bluntly and non-apologetically. Like, I mean, I have a network of other healthcare professionals that I refer to, and I'm proud that I do. I make sure they're competent and they know what they're doing. Because I'm sorry, just because you're licensed doesn't mean you're good. I'm going to say that too. You need to be, people like Bruce who are staying, front of the field all the time. You need to be reaching out to people that are top of their game. And I think optometry, and it's a great thing, optometry is really starting to branch out into special interest areas, right? You're looking at dry eye, you're looking at neuro-optometry, you're looking at specialty contact lens fitting. There's a lot of really neat areas that are developing. And I think within optometry, yes, we need to be comfortable referring out to physio and other rehabilitation professions, but across optometry, we also need to be comfortable. We probably about half of our referrals come from primary care optometrists because they understand what we do, and because we don't do primary care, we just do rehabilitation only. And I love those referrals because it's a colleague giving you the nod, going, "Thanks for doing that," because that's something that we just don't do in our practice.
Yeah. And there's no shame in that. Like, I love that because
No.
there's no shame. You are like, we're all in this to help a patient. We want to better their lives. So wherever direction that might mean, we got to head them that way, and vice versa, right? I mean, other professionals will refer to us for other things that we might be good at, like you said, dry eye, myopia control, whatever it is. But having that network of professionals, whether, like you said, a car accident, whether it's a chiro involved with, neck pain, a speech pathologist, a psychologist, and your optometrist. I mean, that's the network that needs to communicate to help that patient, from 8 years of age, like yourself, live their entire life successfully. And that's huge. But it can start from a small head tilt. Like you said, many parents ignore head tilts. That's a huge one that
Mm.
we get. Oh, they've had a head tilt for a year, and so head tilt, mild things like you were saying, a little bit double vision. Also, parents don't ask their children, right? How come you're not reading? What is the problem? They assume their child is, silly, or whatever the word is, like not wanting to read or doesn't like reading. But probe your children questions. Why are you not reading? And maybe your child will respond by saying, things are double or words are going blurry. That's so important. We're just not involved in questioning our kids to understand their symptoms better. And car accidents is a classic example. Car accidents, we just assume if everything's fine, everybody's fine. It's like getting whiplash and not feeling it till a year later, right? I mean, I had a car accident many years ago, and just this year, like my back broke down, and everybody was probing me what happened. I'm like, nothing happened. Nothing happened. But little did I remember and think that that car accident 4 or 5 years ago could actually impact me now. And that's similar to concussions. Sometimes people don't feel those symptoms till a little bit later, or they don't express those symptoms till later.
Now, yeah, another thing about the head is, you're talking about the head tilt, but there's also like when you have a mild traumatic brain injury, a lot of times there's an overactivation of the sternocleidomastoids, and so you end up having instead of this good
Mm.
posture, you get this. And the problem with that, of course, is that your head's heavy and it's no longer balanced on your spine. It's forward, so you've got this activation here, which being compensated with your trapezius. And so you're going to have like the sore traps, the sore back of the head, the occipital headaches, that kind of thing. And also, we're just a bunch of tubes. Our airway, our vascular
Blood flow.
system, our neurology, and there is a big difference between how my voice sounds like this and when I start talking like this. It it's constricted, and it's not just your airway. It's your vascular system and your neurology in there that's getting constricted, and that's problematic.
Yeah.
And actually, one of the things when I was going through rehab when I was a kid was my speech impediment, which is a stammer. The guy had me read, and then he just pushed my head back so that the back of my head would touch the wall, and had me keep going and reading. And I was astounded at the instant difference, exactly to that point. So when those SCMs are contracting, you get a major effect, not just on speech and muscular, but also blood flow. Yeah, I think that's something that is being really has not been researched anywhere near enough is the amount of the impact of neck muscle abnormalities on blood flow to the head. I think there's a lot of literature now showing that concussions and brain injuries are also a precursor for things like dementia and Alzheimer's and like blood flow to the head. Like, what's that doing? I published a paper years ago. This is going back in my prior life when I was at the University of Waterloo doing a postdoc. But myself and John Flanagan looked at blood flow to the head in normal tension glaucoma patients. So these are glaucoma patients who don't have high intraocular pressures, for anyone who's not an optometrist or an ophthalmologist. And what we found is the eye pressure wasn't the problem, but the diastolic blood pressure was extremely low. So the perfusion pressure to the nerve was pooched. It was the amount of blood getting to the nerve. So it's like, okay, if it's not eye pressure, what else is driving blood into the nerve, right? So it was low diastolic blood pressure, and in the primary care environment, we always look for high eye pressure, high blood pressure because we're worried about cardiovascular events. Well, if my thyroid is underactive or overactive, it's a problem, right? If my body temperature is too high or too low, it's a problem, right? Okay, well, why do we only worry about high blood pressure? Why not low? Like, can't low cause a problem? So I think it's looking at hypotension, not just in terms of, well, you might feel dizzy if you stand up. Well, there might be a whole bunch of other effects
Right.
on the neurology of the system long term as well, right?
Have either of you, I've heard a lot of buzz around like this syntonics, phototherapy. Do either of you, use that regularly? And can you speak to that? Because I don't know too much about it. So, can you speak to what it is and how that could potentially help a concussion patient?
Sure. Photobiomodulation. Syntonics is a form of photobiomodulation, and
Yeah.
photobiomodulation is just basically leveraging light in order to cause change. And we do it every day. Like we go outside, and we utilize UVB to interact with the protein that's 7-DHC, and that actually is the precursor to vitamin D, or the active vitamin D3. That's something in medicine they use a blue light on a regular basis with juvenile jaundice to break down bilirubin.
Hmm.
Now, syntonics is utilizing the light in order to activate the autonomic nervous system. So, blue light is something that actually calms the nervous system and supports the parasympathetic nervous system. The yellows and reds support the sympathetic nervous system. Now, and of course, the greens are right in the middle of your spectrum. And I've actually had really, really good results using some of the greens for my migraine patients. And I think that's what like companies like Avalux are doing. But in optometry, I think that certainly the areas of photobiomodulation that we're seeing are in dry eye with the low light laser therapy. And then in macular degeneration, there's some really cool things happening. I know in the States they've got the Valida system, the Lumitherapy system by Valida, which is an in-office based treatment using a specific wavelength of red light for macular degeneration. In the UK, they've got the iPower Red, which is a small, basically sunglass. And in Canada, we've just got the Aruna light, which is I think the best of the three products because it's a home-based unit, but it's a very robust unit. It's a nice big one. It's not going to break. It's going to last the test of time. It's got some real Canadian rock star optometrists too. So it's a fantastic product. We've been using it at the office, and the whole idea behind that red light therapy is that it activates the electron transport chain via the cytochrome C oxidase pathway. And so it's going to activate the mitochondria to produce ATP. And as a result, it's also going to release nitric oxide, which is going to increase blood flow. So you're getting added circulation and increased energy to your cells. Now, it doesn't do diddly for a perfectly healthy cell, and it doesn't do anything for a cell that's dead. But a weak cell, it's going to recharge it back to the point where it may not die. And I've actually had patients improve a line within a couple months of using that. And the frequency is, I think, 3 minutes every second day.
Yeah. So I think from my perspective, if I take a step back, because I've been doing VT a while, and maybe it's the PhD in me, and I always joke that PhD stands for poor, homeless, and destitute. If you ever want to make money, don't be a grad student. But I always kind of go back, and this is why myself and Bruce get along so well, and how we kind of connected is our brains are like, I'm not just going to take somebody's word for it. I want the data behind it, right? And I think what we found was syntonics initially to me was intriguing, but I was skeptical. So I was like, okay, I'm doing VT. I'm doing all the traditional stuff that we used to do. So I went to a couple of conferences, and I like to think one of my best features is I might be skeptical, but I'll dig, right? I want to know either way. And there's a wonderful saying in vision therapy: start where you are, start where they are, and go where they ain't. And you can apply that to any form of therapy. If I have a rotator cuff issue in my shoulder, the physio is not going to start me up here. They're going to start me within my range of motion and gradually get me to move my shoulder higher and higher. So you start where they are and go where they ain't, right? Patients come in and they're light sensitive a lot of the time in post-concussion syndrome. So you sit there and you go, okay, I'm sensitive to light. And the patients will often say, it's not all lights. It's like fluorescent lights drive me nuts, okay, in particular. So then you have patients coming in trying all these different tints. Some will prefer FL41, some will prefer a blue tint, some will prefer a rose colored tint. Like they're all over the place, right? So part of me was, I need a measurement method to figure this out. So Bruce and I have kind of been talking, and we've been using something called CFF, because Bruce kind of told me he was using it. I was like, oh, that's interesting. Maybe we can use that for syntonics. So what CFF, little box that he's got there, is you basically measure the threshold at which the person sees the transition of a flickering light to a steady light. And it's measured in hertz, right? So the normal range is about 44 to 48 hertz-ish. 50 and above is considered abnormal. 48 to 50 is kind of dicey. So what I started doing very simply was using different wavelengths of light and measuring the CFF on the patients to say, okay, is there a particular wavelength where the CFF drops into the normal range? So the higher the number, the more abnormal it is. And what we started finding was a lot of these patients, to exactly what Bruce said, a lot of these patients were dropping down in that blue range. And when you put the filter on the patient, they weren't all blue, but when you put a blue filter on the patient, like, oh my God, that's so much more comfortable.
Wow.
And I would give some disposable filters, say, can you take it with you and walk around Costco with the blue filters on? The patients would come back and say, it was so much easier to walk around Costco with the filter on. So we knew we were onto something. So syntonics, in my mind, is a very simple way of determining. Sorry, my battery is going low on my laptop. It's a very simple way of finding the point at which they're comfortable and then expanding the range of the wavelength, basically.
Okay. So is this
So
something that you are doing on all your patients, or only every concussion patient that comes in, you take this measurement and then based on that, you're using the therapy, or are you doing it on every patient?
Well, right now, we've really done a deep dive on our older patients. We're now applying it to a lot of the younger patients because the younger patients actually respond much faster. We find syntonics is especially useful in those more chronic protracted cases that are stuck, that are just not moving in therapy. Um, I think what we find is syntonics is a tool. Like what I've determined, and Bruce, feel free to agree or disagree. What I've come to the conclusion of, syntonics is just another tool. It's just like lenses or prisms or plus and minus or vision therapy techniques. It's should not be used in isolation, but it's a good way. If I use an analogy, syntonics sets the soil to be more fertile for the vision therapy to be effective, because what it does is it opens up the periphery and allows the patient to accept peripheral visual information, because these patients just get overloaded. My PhD was basically in visual fields. So think about glaucoma, think about stroke. So I'm measuring my peripheral vision. The irony is we measure visual fields in optometry and ophthalmology. We measure it statically, which if you think about it is idiotic, because we live in a dynamic world. Things move, right? So if you think about a syntonic visual field, how do we determine if the patient's getting better or not? We have data on this on over 50 patients. Bruce and I have data that we put together on this. And basically, you have a patient, you cover one eye, you move a target in from the periphery. So they can't look at the target, obviously, but they have to tell you not only when they can see it, but when they can tell what color the target is. So it's white, red, green, and blue. And what you'll find with a lot of these patients, they'll have very constricted fields. It's almost like a Goldman field, but it's really constricted. And then as you start to use different wavelengths of light on the patient, what you start to find is, starting with the wavelength that's the most comfortable, you'll start to see that field start to open up. And I think what that's showing is you're not fixing the visual field. You're putting the patient in a more balanced position. Remember, the term syntonics comes from the word syntony, which means in balance. So to exactly what Bruce said, it's taking, if you think of a seesaw, it's taking the sympathetic and the parasympathetic and leveling them so that the patient's not going to recover if they're chronically stuck in a fight or flight mode. They're just not going to recover. So syntonics helps to bring that down, helps to get the periphery open, which will then allows the vision therapy to be much more effective and actually stick. And that's, from a clinical perspective, that's the way I look at it. There's a couple of good books, actually. When I go back to Harry Babbitt, that's probably the original book on syntonics, and he's actually an MD. And then Harry Spittler is the syntonic principle. So if people want to read more about it, they can. I am really looking into why blue. I mean, both Bruce and I are convinced that blue does help in a lot of these cases. We've seen it with the drop in the CFF, seen it symptomatically. The patients will say, I can have a slight syntonic D or depressant blue filter, and it really helps. Now, the goal is not to keep them in that forever. But what we find is, um, I think neurologically, and maybe again, it's my PhD brain, I like to have an anatomical reason why it's helping. And I think why it's helping is concussion patients have a problem with the periphery, right? They can't handle peripheral motion, even though the acuity is good. That's why a lot of clinicians will get confused. They go, I don't get it. The patient sees good acuity, but they're complaining that their vision's off. And by the way, for the optometrists out there in primary care, these will be your chronic non-adapt patients. These will be the ones that they never seem to settle with any prescription that you give them. And I think it's because, think about the fovea, right? We have very few, if any, blue cones in the fovea. Outside the fovea, the red to green to blue cones, the ratio is 8 to 4 to 1. So for every 13 receptors, you've only got one blue. So if you put a blue filter over top, what are you doing? You're allowing the patient to go more peripheral in a way they can handle.
Hmm.
Again, it's starting where they are and going where they ain't. I mean, we can overcomplicate this, but it really comes down to that simple concept of, here's a range of filters that we could use, find the one that the patient finds the most comfortable, and yes, we can confirm it with the CFF, start with that, and then slowly try to desensitize them to different wavelengths of light. And I think it's really desensitization, because I've asked Eric Singman from Johns Hopkins, I've asked, who's the other guy? He was at Stanford. Gijal, I think is his name. But they're both MD PhDs, very smart individuals. And I said, photophobia, light sensitivity and post-concussion syndrome. Why does it happen? What's the cause, right? Simple question. Both of them gave me an answer that was different, which tells me we don't know. Um, what was interesting is the best definition I've heard. This is not my definition. I can't remember where I heard it, but it's a really good definition. Probably, of course, from somebody way more intelligent than me. And what they basically said was, photophobia is light information that the brain can neither organize nor ignore. And I love that.
Stress.
Can you
It's
repeat
stress.
that?
Thank
Can you repeat that?
you. Light sensitivity is light information that the brain can neither organize nor ignore. So I can't organize it, but I can't ignore it. I have to register it as something. Light sensitivity. So what we find is photophobia, light sensitivity, markedly comes down when you use the right tint and the right approach in syntonics. And as you progress through VT, if vision is at the core, then you'll see the light sensitivity start to come down. Now, if you have neck issues and other things involved, you have to address that as well.
Right.
But since I've incorporated syntonics into my treatment, I cannot imagine doing vision therapy now without it.
Yeah. That's
To go back to what Pat was saying about just sort of the fact that we just in optometry typically will measure. We're sitting there static, looking 20 feet away at an object that's static. We've got two visual systems. We got that 6% that what is it, and then that 94%, which is where is it and what am I? Where am I in space? And that's the part that is it works along with your vestibular system and your somatosensory system for your balance. That's unfortunately the system that collapses when you have a traumatic brain injury. The dorsal stream just shuts down, and so you're almost in that tunnel vision. Very similar to we're Canadian. We have all driven in a snowstorm. You turn on the high beams, all you see is the snowflakes. You don't see the road.
Yeah.
That's focal binding. And that's a big problem with traumatic brain injuries. You're so focal, that whole periphery is gone. So your balance is gone. That the visual motion sensitivity. The system is not playing well together.
That's a great way to put it. Thank you guys. I mean, this was so helpful for not only healthcare professionals, but I think parents out there, who have children who've experienced concussions or may have these symptoms, to reach out for help. So I think the burning question is, where and how can anyone find you guys? So we'll start with Bruce, if you don't mind letting our listeners and viewers know, how can they find you if they want to seek help.
Okay, I practice in Fort Francis, Ontario. And yeah, you probably have to look that up because
Yeah.
nobody knows where. It's right in the corner of Minnesota, Manitoba, on the Ontario corner right there. You can look me up at lidkeaoptometry.com. I'm available at basically all the socials.
Excellent. And Patrick.
Thanks. Well, we're two clinics. We got one in North York in Toronto and one in Guelph in Ontario. Our website's View Therapy, so that's VUE, viewtherapy.ca. We also have something called a discovery call, which you can just jump on. If you're a parent or you're a patient, like, I'm not sure what the next step is, you can book a discovery call on your schedule. And one of our team, we got four, Bruce is an FCOVD as well, but we got four FCOVD doctors who are fellowship trained in this area from the US, so they can jump in and kind of give you some help, and the team will just help you to direct you, and there's no cost to it, but it's just kind of a counseling call to say, okay, where are you in your journey, and how can we help with the next step? And sometimes we'll say it's appropriate to see a neuro-optometrist. Sometimes we'll say, based on what we're hearing, you need to see this person first before you see us. So we'll try to help you with the sequence of events too. But the one in Toronto and North York is on Bathurst and Lawrence, and in Guelph we're on the south end of Guelph, so very easily accessible from the 401.
Excellent. Thank you guys so much for your time, your expertise, and I hope we've made an impact today on others, and and there are people that will seek help for their concussions. So thank you guys.
Thank you.
Thank you.
Thank you, listeners and viewers, for tuning in. If you want to catch more episodes of Uncover Your Eyes, make sure to follow or subscribe on your favorite podcast platform and on YouTube. To learn more about me, follow me on Instagram at Dr.Meenal Agarwal. Until next time, keep those eyes uncovered.